Hello, good afternoon, everyone. My name is Deontay Marquis. I'm a family nurse practitioner, and today I will be talking to you for the next hour about diabetes and specifically how we can improve our care and management of patients with diabetes. And this lesson today is specifically for the registered nurse. So let's begin. So I've outlined some course objectives, some specific topics that I want to make sure we touch on and leave with enough information that you feel comfortable to put what we talk about here today into your practice. So the first of these objectives is identifying signs and symptoms of hypoglycemia and hyperglycemia and some emergency treatment plans that we need to know to care for our patients who unfortunately find themselves in a life-threatening situation due to their diabetes. So our next objective is identifying elements of a proper nutrition plan and other dietary concerns that are specific for patients with diabetes. We all should be changing the way we eat, always improving our foods and nutrition. But this specific population, they really need help and focus to make sure they are uh, abiding to proper nutrition and diets, but they need that focus because their life depends on it because of their diabetes and inability to regulate their blood sugar. Next would be identifying comorbidities, which make diabetes care in itself very challenging. As I'm sure you are probably already aware or may be becoming aware of, patients with diabetes, their care can be very challenging at times. So we're juggling their blood sugar, regulating their blood sugar with insulin, helping them with their diet. But a lot of the times they have comorbidities, which are accelerated because of the diabetes, and sometimes vice versa. Sometimes their comorbidities can make their inability to regulate their blood sugar even more difficult. So we're going to talk about a few of those comorbidities today and how they're connected and how we can disconnect them and attack them individually to improve our patient's life and well-being through our care. Next, we will be talking about key elements of a good diabetes care plan. So after we've talked about all this information, I want to wrap it up at the end by talking about how we can create a care plan now that we know about the comorbidities that make diabetes care more challenging, and we'll know a bit more about the proper nutrition plan and dietary concerns that uh, they'll need to be considerate of, and we can help them be considerate of. We're going to tie all that in together and create a care plan, or at least teach you all how to create a care plan that's easy, that's comprehensive of what we'll need for their care. And of course, we can tailor that care to each specific patient because even though they're all may have the same diagnosis of diabetes, we know that the care we provide has to be individualized because every patient is indeed their own individual. So, uh, our first slide here, I included an excerpt from the Journal of American Diabetes Association. So, I'm gonna give you a minute to read through, and then I'll read through this excerpt together with you and point out some key takeaways from this excerpt, which would be the reason why I added it here. Okay, so the title is Diabetes and the Long-Term Care Population. So that's what really drew me to this excerpt in the Journal of American Diabetes Association, the JADA. So it says in this excerpt, in the long-term care population, The prevalence of diabetes ranges from 25% to 34% across multiple studies. So, in the long term care facilities, as many of you may be working or beginning to work in, then we need to be conscious of this fact that more than one fourth of those patients are going to be diabetics. So that just stresses the importance of understanding the information we're talking about today to be able to apply it into our daily care for our patients, because the chances that we will be taking care of a growing number of elderly patients living in a long-term care facility is just increasing as the years go by. The estimated total cost of diabetes in 2012 was 245 billion. The challenge of caring for older adults with diabetes arises not only from their clinical heterogeneity, but also from their considerable variability in living arrangements and social support, which significantly impacts diabetes management. So this sentence is talking to us about how the patients all may have the same diagnosis, which is diabetes, but the difficulty and challenge in providing care to these older patients is because of the variability in their living arrangements, where they come from, the families who cared for them, their social support. All of that has a significant impact on how their diabetes needs to be managed and how they're used to having their diabetes managed. So that it's pointing out here is where the challenge comes. Let's read on a bit. Some older adults live independently, some in assisted care facilities that provide partial support with medical management. So some of our patients are going to know how to take care of themselves 100%. And some of them may only be able to take care of themselves 50%. So it's going to be a lot of education. And some patients are really going to be coming into the facility at a learning curve, a very steep learning curve. So we need to have this information ready to share with them and be able to properly manage them and help them manage themselves. Um, as the challenges and self care responsibilities change in these different environments, different recommendations are needed for each setting on how to manage diabetes in individual patients. So, again, it's just telling us that we need to have a strong hold on diabetes care and management, because we will need to individualize the care we give to the patients in our long term care facilities to them individually to manage the diabetes appropriately. So first, we're just going to do a little reinforcement of knowledge that I'm sure you already have, but just we're going to go over it again here and try and give you some easier ways to remember it in case maybe you forgot some of the information. So first, we're going to talk about hypoglycemia and some signs and symptoms that a patient may be experiencing hypoglycemia. So first thing we look at this slide is the picture to the right, and the bold font at the bottom catches your attention. You'll see in the picture on the right, hypoglycemia. Some common symptoms that patients will present with include, but are not limited to, sweating, pallor, irritability, hunger, sleepiness, and lack of coordination. So those are some primary symptoms. And there has even been a mnemonic devised to summarize and make it easier for us to remember these symptoms. And that mnemonic is the word tired, TIRED. So in bold font at the bottom, you see I have the word hypoglycemia equals tired. Tired because patients with hypoglycemia tend to present with tachycardia. They present to be irritable, restless, excessively hungry, and diaphoretic. Just as the picture is demonstrating those symptoms there. TIRED is the acronym that I use to remember symptoms for hypoglycemia. And I just think of it as a patient may have hypoglycemia because they haven't had anything to eat. There's a low amount of sugar, so they're tired. And then that's when I recall all the parts of the acronym, TIRED. Now, at what blood sugar level is a patient hypoglycemic? Well, hypoglycemia is classified in several different ways, but the most common and the way that I'm going to share with you is a blood sugar level of less than 70 milligrams per deciliter. That's when you can expect the patient to exhibit mild symptoms of hypoglycemia. Moderate symptoms would be less than 70 as well. It's not that big of a change. But once a patient falls below 55 milligrams per deciliter, that's when you can expect to see more severe symptoms, especially if the patient has been less than 55 for longer than 5 minutes. Of course, the longer the body goes without enough sugar in the bloodstream being transported to the different tissues throughout our body and our brain, these symptoms will become more exaggerated and severe symptoms will set on. Um, and eventually, the blood sugar will continue to decrease. And the worst symptom, of course, the patient may fall into a coma. So, as you can see here, 70, 55, and 40 um, is the correct milligrams per deciliter for hypoglycemia. As you see, I've classified the symptoms. So mild symptoms, we remember the acronym TIRED, and it's a blood sugar less than 70. So this is when we can expect to see the patient have some signs of irritability. They may be becoming restless, moving about in the bed nonstop. They may be complaining that they're very hungry. Maybe you noticed that their blood sugar was a little low and they're extremely hungry. The appetite has increased a lot since you've been caring for the patient. Um, Diaphoretic, sweating, tachycardic, and irritable. Now, if the blood sugar is less than 55, we can expect a little more neurological symptoms. So blurred vision, confusion, slowed or even slurred speech. And last, patient whose blood sugar falls less than 40 milligrams per deciliter, we can expect those more severe symptoms that I told you about, such as coma. Some patients can even, a low blood sugar can bring onset of seizures or convulsions and hypothermia. That's a symptom of hypoglycemia I haven't seen personally, but seizures and coma are definitely, we want to try and do our best to manage diabetes care so blood sugar never falls below 70. Uh, but if it does fall less than 40, we can expect those symptoms. So if you check up on a patient and their blood sugar is 37, knowing that the possibility that they could slip into a coma with a blood sugar that low, it should really expedite your care to take the proper action to bring their blood sugar back up. Let's see. So treatment protocol. So what do? We run into a patient whose blood sugar is in one of those three zones of mild, moderate, or severe symptoms. What should be our first step of action here? And you see to the right, I have a picture of orange juice. That's my go-to treatment for patients experiencing hypoglycemia. Uh, Orange juice or glucose tablets, but usually I go for the orange juice. Usually works the best for me. So our first step in treating a patient with hypoglycemia is to offer 15 to 20 grams of carbohydrates. And just in case you're not sure what 15 to 20 grams of carbohydrates may look like, you should definitely Google or look on the nutritional label of the packages at your facility or hospital to be familiar with what 15 to 20 grams of carbohydrates looks like. So in an emergency, you know what to grab and exactly how much. But if you weren't sure, 4 ounces of juice, orange juice, um, or 4 ounces of regular soda. Some patients don't like juice, they prefer soda. In an emergency, I always like to give the patients their favorite drink because sometimes they may uh, just be very irritable and not following instructions, kind of confused. So just to break past that little delay of going back and forth to get them to drink something, I just give them their favorite drink, their favorite regular soda. So 4 ounces of juice, 4 ounces of soda, or 8 ounces of milk. Or sometimes the patients have their own glucose tablets. Preferably, I prefer juice, 4 ounces, and I don't give them any more until, and that takes me to step two, until we recheck their blood glucose in 15 minutes. So we see that the patient's blood sugar is low, and we offer them 15 to 20 grams of carbohydrates. Uh, 15 minutes later, we check their blood sugar and it's only risen from 55 to 60. So we would have to give them an additional 15 to 20 grams of carbohydrates and then recheck again in 15 minutes. Unless their blood sugar responded beautifully to the 4 ounces of orange juice. And when we rechecked their blood glucose, it was greater than 70. So if it's greater than 70, we would offer them a meal, something with a little more sustenance to maintain that um, that appropriate blood sugar level. So if that's the case, then we move into step four. We treated their blood sugar, we waited 15 minutes, it's where we want it to be. So now we're on step four, which is if the blood glucose is within normal limits, offer 7 grams of protein. That's only if mealtime is more than 1 hour away. So we did everything right, but somehow between breakfast and lunch, the patient ate lunch very early that day, or maybe they went for a walk too soon or took too much insulin. For whatever reason, their blood sugar dropped. We offered them the juice, we brought it back up. Um, we checked their blood sugar, it's where we want it to be. But mealtime isn't until noon, and it's only 8:30. So we can't just leave them sitting there without anything to eat because their blood sugar is going to just drop again before lunch. So if that's the case, we need to offer them 7 grams of protein. So cheese and crackers is good, or maybe some type of snack. I was being funny there. I have a nice big juicy steak. Uh, they'd love that. So some kind of protein, whether it's meat, eggs. Maybe you want to give them a little more, encourage something they left over from breakfast, some sausage, some eggs, some cheese, um, just some type of protein. Maybe they have an Ensure shake. We want to offer 7 grams of protein. Now, we've taken care of our patient with hypoglycemia. We restored their blood sugar to where we want it to be. We go into our next patient's room and they have hyperglycemia. So the first thing here you'll see is the hyperglycemic symptoms, the image I have to your right. You see some signs and symptoms would be dry mouth, increased thirst, weakness, headache, blurred vision, or frequent urination. These are all symptoms of hyperglycemia. Now, there isn't a easy mnemonic that's floating around out there to help you remember these symptoms like hypoglycemia and tired. But the way I think of the hyperglycemia symptoms is I call it the too much food effect. So basically, when I've eaten too much food, I feel tired, I'm very thirsty, I'm drinking a lot, have to feel like I have a dry mouth. And because I'm drinking a lot, then I have to use the bathroom a lot. So the too much food effects would be fatigue, dry mouth, polydipsia, and polyuria. So just think of you ate too much and now you're on the couch, you're just feeling very much like a sloth, fatigue, dry mouth, you're thirsty, and because of that, you're urinating a lot. Now, mild symptoms of hyperglycemia begin at 180 milligrams per deciliter blood sugar level. Diabetic ketoacidosis, uh, those symptoms can present at 250 milligrams per deciliter, which is another level of the signs and symptoms are completely different. We'll touch on that in a minute here. So 180 181 is considered hyperglycemia, and greater than 250 is usually when we see diabetic ketoacidosis. But just because a patient's blood sugar is greater than 250, that doesn't mean that they are in DKA. That's just the most common level at which it's been documented to present. So hyperglycemia, let's clarify that a little bit. Some of you may have been confused. I know it confused me a little bit when I first was trying to learn the distinctions between the two. Now, the American Diabetes Association recommends that blood sugar 1 to 2 hours after the beginning of a meal should be less than 180 milligrams per deciliter for most adults. That's whether they have diabetes. For most adults, non-pregnant adults with diabetes. So if they have diabetes, then within 1 to 2 hours after the beginning of a meal, not after they finish, the blood sugar should be less than 180. And this should be about the peak or the highest blood sugar level that we'll see in a patient is 1 to 2 hours after they begin their meal. Because that's when the food's just starting to get broken down, all the sugars and carbohydrates are being extracted from the food that they just took in. And now this is translating into the bloodstream. Again, this target may be individualized for certain people. The doctor may tell a patient that their hyperglycemia is 220 or 200. They may change the rules for them depending on several different factors. How long they've had diabetes. Maybe the doctor's trying to manage it a bit tighter, their age, their cognitive status, cardiovascular complications. There are many different reasons why. Maybe hypoglycemia unawareness. Maybe the patient tends to become hypoglycemic very quickly. So the doctor tells them, hey, we're going to move your target range from 70 to 180 to 100 to 220, just to give them a little extra cushion room. Maybe this patient's been having frequent episodes of hypoglycemia. So the doctor's just trying to manage it a bit. So this is why we need to talk with the patient, talk with the doctor to discuss their target blood sugar goals and why it's a little bit more, it's different than hypoglycemia to have those outlined numeric values associated with the distinctions we make between hyperglycemia levels, as I did with the hypo with mild, moderate, and severe symptoms. So treatment for hyperglycemia. It would usually be a rapid acting insulin, notify the physician, and assess for signs and symptoms of DKA. So very, very simple there. And see, I have the table showing you the sample of a sliding scale insulin orders. But again, with diabetes and especially with hyperglycemia, it's very individualized, as I'm sure you know in your practice. The way the numeric value of insulin and the type of insulin that the doctor chooses. So again, that's why it's important to talk with the doctor while we're managing our patients, give them all the information, the blood pressure, the diet, the activity level, the patient's mood, how they've been eating, what they've been eating. The doctor needs all this information because the management of diabetes care is, for very few patients, do they find, especially elderly patients, do they find a system that works flawlessly, that doesn't need some tweaking every now and then. Just like you and I, sometimes we may follow a diet we've set for ourselves strictly, or we may stray from it a bit. A doctor needs to know what's going on in the patient's life to accommodate for those severe swings, because these patients have comorbidities which exaggerate their meals that they have sometimes and makes managing diabetes a bit more difficult. Now, what's the difference between hyperglycemia and diabetic ketoacidosis? Other than diabetic ketoacidosis begins somewhere around 250 milligrams per deciliter. Well, if the blood sugar is greater than 250 milligrams per deciliter, the first thing, as you saw from the last slide, is we should assess the patient for DKA. So when we're assessing the patient for DKA, we're looking for certain symptoms. The most common in my practice is fruity scented breath. This is the easiest to note and it most always hints toward DKA. Now, if you suspect the patient may be in DKA, but it's not fruity scented breath, or maybe you can't distinguish between fruity scented breath or not, then you would look for ketones in the patient's urine, sending a urine sample off to lab. Note other symptoms of DKA would be abdominal pain, nausea and vomiting, as well as polydipsia, increased thirst. So those are all symptoms indicative of diabetic ketoacidosis that we want to make sure we're looking out for. Um, this brings me to our conversation about what type of nutrition and just some information and things to be aware of for patients with diabetes to help them better manage. So I have here, just because I know we're nurses, we're not nutritionists, but we need to have knowledge of what nutritionists know to share that information and help better manage our patients. For example, here, you see these 6 fruits and their sugar level and serving size. Common serving size is 1 cup of grapes, a cup of cherries, 1 whole banana. These are foods that to me and you or patients without diabetes would not be a problem. But in comparison to these foods, you can see the sugar level in the previous foods are much higher than these seemingly similar foods. So instead of having 1 whole banana, which is 14 grams of sugar, the patients can have 1 whole papaya, which is 12 grams of sugar, or 1 whole guava, which is 5 grams, or even less than that, 1 whole avocado, which is a half a gram of sugar. So we need to learn how to substitute these little snacks, and not the ones that seem healthy, but for these patients, for the diabetic population of patients, we really need to know exactly what we're giving them, because we want to help them manage their blood sugar. Because in the end, as we'll talk about in a moment here, the comorbidities will play up the symptoms of the diabetes, as will diabetes play up the symptoms and the effects of the disease on the body within the other comorbidities as well. So just a bit of information here. So mangoes, grapes, cherries, they all have a high amount of sugar, as well as watermelon. A lot of people, watermelon has a lot of water. Yes, it's a watermelon, but it also contains a lot of sugar, and that's what draws people to it. And of course, if you eat more than 1 medium wedge, which some people sometimes do, without knowing about a serving size, then you can easily eat as many sugars as would be in a candy bar. So we want to make sure we're educating our patients about these things by educating ourselves and using this information to improve our care of them. So, uh, more about nutrition for these patients and what we can do to help them eat better, because we know the blood sugar is really a direct indicator of the foods that they're eating. So if they ate something that we thought was healthy, or something that we knew wasn't healthy, we want them to live out the rest of their life, enjoy the rest of their life. And for a lot of people, that's food, and that's okay. But we want to make sure that we're doing everything in the right proportion. So using a 9-inch dinner plate, uh, this is what the plate should look like. Half of the plate should be green. So in my opinion, that's where we should start, because that limits the amount of food you can put on the rest of the plate and limits overeating, and make sure that we're getting the proper intake and nutrition that we need. So salads or greens or broccolis or carrots or the avocado you'll see there, anything that's green, we want to make sure we fill half of the plate, even if we don't want that much, because what that's going to do is it's going to limit the amount of the other foods that we can have on our plate to make sure we keep that balance. And that's what's important, finding and keeping the balance. So once you've filled up half of a 9-inch plate with non-starch vegetables, you can then go ahead and fill 1/4 of the plate with a lean protein. Some patients may have blood disorders such as anemia, so they may need a little more protein. We want to make sure we account for this because sometimes, as we know, sickle cell disease patients, they may have iron deficiency, so they may need this increased amount of protein, or a diabetic patient specifically, is we want to make sure we're giving them just the right amount. So we have half of the plate with non-starchy vegetables, 1/4 of the plate with lean protein. That would be cheese, chicken, turkey, beans, tofu, or eggs, things like that. Um, and we want to fill 1/4 with a grain or starch. So we have half, 1/4, and there's 1/4 of the plate left. And that's where we're going to put our potatoes, our rice, our pasta, or our bread, things like that. Um, and that's how you uh, change the dynamic of dieting means I can't have the things I want. No, dieting means you're finding a balance between the things you want and the amount of them you want, in combination with the things you may not be so excited to eat, such as non-starchy vegetables or cauliflower and things like that. So we just want to build that routine into our patients and also give them that education so they can build that routine for themselves and start to make those decisions for themselves. But until they can, we're going to help them along the way. So now we've reached just about the middle of our presentation, and I'm going to talk to you guys a little bit about uh, comorbidities. And you could see from the image I have there of the man trying to push a ball up a hill, some comorbidities can be very challenging. So there are 3 main comorbidities that really, in my opinion, create a challenge for healthcare workers and nurses especially to provide optimal care for patients with diabetes. Those 3 challenges include hypertension, chronic kidney disease, and cardiovascular disease. So in my opinion, those are the 3 big challenges. Now you'll see, if I move myself out of the way here, diabetes and comorbidities. So here you see this bright image here. But before we jump into that, I want to talk a bit about the antihypertensive drugs, because hypertension is the first challenge that's very prevalent amongst patients with diabetes that creates and maximizes the negative effects of that are caused on the body by diabetes. Having diabetes and hypertension really maximizes those effects, and they both play into one another synergistically to make things more difficult. So, antihypertensive drugs. There are many different classes of antihypertensive medications that the doctor may be using to control our patient's blood pressure for diabetes. But the 4 most common that you might likely see are ACE inhibitors, ARBs, thiazide diuretics, and calcium channel blockers. Now, the problem is not with the medication so much as there tends to be a medication therapy uh, that has the least negative or sometimes no negative interactions with diabetes medications. That's not usually the problem, as many people may think, is that the doctors have trouble finding medication that works for the patient and that doesn't interact negatively with medications that the patient may be taking to control their other disease, their comorbidity. The problem is more so in the diseases themselves. So, as you know, diabetes affects the body on a microvascular level. Now, having hypertension does the same thing. So, in diabetes, when patients have chronically high blood sugar, that means that the vessels, our blood vessels, are getting clogged, sometimes with sugar, if you will, that's in the blood sugar. We have more that's in the blood. We have too much sugar in the blood because we have high blood sugar. Now, patients with hypertension, that means the blood vessels are also thinning or growing smaller in diameter because plaque is building up. And hypertension is created as the body tries to compensate to pump blood through our vascular system that has this plaque buildup along the outside. So now when you combine those two, the narrowing of the blood vessels with the increased sediment or sugar, if you will, inside the blood, it exacerbates things like retinopathy. And these patients become more likely to develop congestive heart failure or congestive heart disease because not only now do we have sugar that's floating around with our excessive sugar that's floating around with the blood, we have narrowing blood vessels because of the hypertension. So as you can see here, um, microvascular issues that become more likely. End-stage renal disease is attributed to hypertension or diabetes, an increased risk of retinopathy. Peripheral vascular disease, diabetes increases the risk of PVD by 2 to 4 times. And this risk is even increased more with patients who have high blood pressure. Let's move to this area here, this green area here. 40 to 80% of diabetics have hypertension. 40 to 80%. So in the beginning of the presentation, I included that excerpt from the American Diabetes Association, where it talked about how 25% to 35% of patients living in a long-term care facility will likely have diabetes. So out of 100 patients in a long-term care facility, 25 to 30, so let's just call it 25 of them will have diabetes. Now, of that 25%, anywhere from 12 to 20 of those patients can have diabetes and hypertension, as diabetics are 2 times more likely to develop hypertension, which increases the risk of stroke by 2 times, and it increases the risk of coronary heart disease by 3 times. So as I hope you're becoming aware that these comorbidities, they really compound and maximize the negative effects of one another, which is why it's so important for us to really step up how we manage the patient's diabetes, because we want to limit, if not completely eradicate, the negative effects of diabetes. And that can be done. That can definitely be done through managing their blood sugar and through managing their diet. Now, move myself back here. I like to be on this side. Now, another comorbidity of diabetes is chronic kidney disease. This is something that many diabetics end up with, as diabetes is the leading cause of kidney failure. So not only do a lot of diabetics go through a stage of chronic kidney disease. Um, it's the leading cause of kidney failure. So in the end, it leads uh, it leads up to a lot of deaths are related to chronic kidney disease because of from patients with diabetes. Let's see, diabetes and high blood pressure are the major causes of chronic kidney disease in adults. 15%, 37 million adults are estimated to have chronic kidney disease. And every day, 340 people begin treatment. So that's 340 people every single day who begin treatment of CKD, which is either a workup for a transplant or they are started on dialysis because their kidneys are no longer able to filter the waste from the blood. In 2008, almost 50,000 people with diabetes began treatment. That's that's more than probably triple today. Um, so chronic kidney disease, hypertension, and our last one is just generally cardiovascular disease. Diabetes is treatable, but even when glucose levels are under control, it greatly increases the risk of heart disease and stroke. So even if we get them under control, because of the small amount of time that that extra amount of sugar is in the patient's uh, bloodstream, as their pancreas isn't giving them the on-time secretion of insulin that me and you have, that little bit of time that they have too much blood sugar until they give themselves insulin, over time, as they grow older and they now are living in a long-term care facility, that increases the risk of heart disease and stroke greatly. That is because these patients have diabetes and also because of the other conditions that that are so commonly associated with diabetes. We talked about high blood pressure, but what many of you may not know is that abnormal cholesterol and high triglycerides is another common symptom that's associated with diabetes that increases their risk of having heart disease and stroke because they have abnormally high cholesterol levels and high triglycerides. Also, as elderly people, just in general age, sometimes they become obese due to decreased mobility or limitations from other diseases that they may have, or just injuries or common soreness. Their movement and mobility decreases, and because of this, sometimes we find that the elderly population becomes obese. Well, the elderly portion of the population that has diabetes, if they become obese, it can lead to insulin resistance, which can then even increase their hypertension because now that blood sugar level is going to be high for an even more prolonged amount of time, decreasing the amount of space for the blood to flow, therefore narrowing the vessels in the body, decreasing the amount of space for the blood to flow, which in turn the heart has to pump harder, and the pressure that's exerted in our cardiovascular system is increased. So these patients have increased hypertension. So I hope you guys are understanding and seeing how all of these comorbidities are tied together, and they're all leading back or stemming from diabetes. So this is why this population is one which we really need to give our focus to. And how can we give our focus to this population? And we can do that by managing the disease, by developing a care plan. Now, hopefully all of you were taught about developing care plans in your formal nursing education. But if not, then we're going to talk briefly about it here today. And I want you to do some more research on it if you still need some clarification, because I'm not here to teach you about it, but to reintroduce it to you as an option to improve our management of diabetes. Okay, so the first step in developing a care plan is, of course, to collect data. So, what type of data will we be collecting? We'll be collecting data about the patient's nutrition, about their blood sugar trends, about any symptoms they may be experiencing. And then we want to analyze that data. So, from that data, what can we learn? Well, we learn about what the patient's eating habits are, what they're eating, how much they're eating, if they're exercising, what their blood sugar trends on the current insulin regimen the doctor has them on. And we take that data and we analyze it. We develop our nursing diagnosis. We set priorities of care to address the diagnosis and the issues causing. And then we establish goals and outcomes to measure our success or track our progress towards meeting the client's goals. Maybe the client's goal is to improve their diet, to regulate their blood sugar so much that they want to wean themselves off of a high dose of insulin that the doctor unfortunately bumped them up to. Or maybe they want to limit the amount of hyperglycemic episodes that they have in a set amount of time. So by collecting data, analyzing it, using our diagnosis to set priorities and establish these goals for the patient and desired outcomes, we can get a better management of the diabetes. And so by doing this, we can point out the areas that need help, set clear goals, share them with the patient, and track our progress towards those goals. So here is a sample of just what some information in a care plan might look like. So here, this patient has a presence of bleeding um, from some skin issues, from poor home cleaning, so some infection. The family nursing problem, inability to provide a home environment conducive to health maintenance. Specifically, ignorance of the importance of hygiene and lack of knowledge. So the goal of care after the nurse implements their chosen intervention, which you can see here, um, the goal is that the family will be able to eradicate the presence of these unwanted sites of vectors causing diseases and therefore maintain a home environment conducive to proper health. Now, how does the nurse propose to reach this goal? Well, he or she proposes to reach this goal by discussing the importance of proper sanitation, so educating the patient, giving them some alternatives and methods to eliminate breeding sites of these vectors, emphasize to the family proper storage of food, so talking to them about how to store their food to make changes to the way they live, and instruct all family members specifically about stagnant water. Maybe that was a specific problem of breeding place for insects that the nurse saw and wants to address. So very personalized for this family. So that's what I want you guys to see is just the personalization that we need to put into our care plan and not just make a cookie cutter, one fits all type of plan for all the patients um, with diabetes who need some assistance in managing the effects of the disease. So what we need to do is use all the information that we have by conducting a thorough, proper assessment into the patient's well-being, mentally, physically, emotionally, and use all that information to help find the root cause and offer individual, very specific goal setting and ways to achieve those goals with the patient. And last but not least, something that could not end this presentation on is talking about diabetic foot ulcers, especially in the long-term care facility population of patients that we're going to be caring for. So, wound care, specifically for patients with diabetes who are elderly, we should be looking for diabetic foot ulcers. This should be a part of our assessment every day, is checking their feet. How can we prevent infection uh, in patients who we may think are more susceptible than others to develop an ulcer? Well, avoid walking barefoot. Have the patients wear socks or shoes, preferably socks even when they wear certain shoes. Make sure it's a soft and not a rubber material of their slippers. And this is can be a big issue. Also, make sure they're cleaning thoroughly and drying the foot thoroughly before, and just checking the foot every night. They may be stepping on something, or they may have stepped on something, caused a cut, and we know that individuals with diabetes have been known to have poor wound healing. So wound care, elements of wound care for patients who have already sustained some type of diabetic foot ulcer, we want to prevent infection. So that means cleaning the wound daily and using dressing or a bandage to cover the wound after we clean it. Also, if the doctor has ordered any type of medication to apply, we apply that, and then of course you dress the wound. Also, using debridement as a treatment, which nurses have full authority to do, which is removing any dead skin or tissue. If you're unsure, ask the doctor, but removing dead tissue opens the wound up, yes, but it gives a chance for it to heal properly, because under that dead skin, it likely has bacteria that is keeping the wound from healing appropriately. It's probably still a sore area. And if the patient walks barefoot or steps on something else, and that area is going to be the first to reopen up, and it's going to open up even worse than it was previously. Also, if we're seeing some breakdown on the patient's foot, or the patient already has a diabetic foot ulcer, then we want to practice offloading. So offloading is just, if you remember, um, floating the foot from pressure. So what I like to do is, if a patient's sitting in a chair, you put some pillows in front of them, and you place uh, their lower part of the leg or the calf on top of the pillows, and therefore their foot is just floating in air. Or you can do the same thing if the patient's laying in the bed. It's just no pressure, nothing's touching the foot, giving those sores some time to heal and rest. And last, but the most important thing we can do for patients who have a diabetic foot ulcer, which is a part of wound care, is tightly managing their blood glucose and other problems. I talked a lot when we were talking about comorbidities about um, the microvascular changes that diabetes and hypertension and cardiovascular disease place on a patient's body with diabetes. So we know that if all these microvascular problems are causing a decreased blood flow or causing the body to work harder, then then what our goal should be is to um, manage the blood glucose better, so it decreases those microvascular issues, which are decreasing blood flow just a bit. So more blood flow and oxygen can get to the extremities, like the patient's foot, and help the tissue to heal. So that are our 5 most important things to remember under wound care for patients with a diabetic foot ulcer. This brings me to the end of the presentation. But before we end, I have some questions for you guys and gals. So review question number 1, just to see how you guys were paying attention and remembering the information we talked about today. The first question is, patients with hypoglycemia exhibit a group of signs and symptoms we referred to with the mnemonic TIRED, T-I-R-E-D. What symptom does the I in the mnemonic TIRED stand for? Is it A, illusions, B, ischemia, C, irritable, or D, inconsolable? And I'll give you a moment to answer that, and then we'll go through the correct answer. Okay, so the I in the mnemonic tired, which is the mnemonic we use to describe a group of symptoms that are commonly associated with hypoglycemia. What does the I stand for? The I stands for irritable. If you remember, we talked about the patient, the tired, tachycardia, irritability, restlessness, eating. We talked about this, so I hope you guys got it right. And remember that mnemonic, tired. Now, review question number 2. This one's a little bit more difficult just to see who was paying attention really close today. So, a patient is struggling with her diet and wants to improve food choices to lower her blood sugar. Which of the following fruits should you recommend to the patient that have the lowest amount of sugar? So, which fruit has the lowest amount of sugar? The patient comes to you and says, Nurse, such and such, I want to change the way I eat. I want to eat better. My blood sugar is always high. Which one of these fruits should I eat? I really want a snack. Which one is the best for me? Is it a cup of cherries, a cup of strawberries, a cup of grapes, or a whole banana? Which snack will provide the lowest amount of sugar to this patient? All right, guys, give you a minute. All right. So hopefully you chose a cup of strawberries. A cup of strawberries has the lowest amount of sugar as opposed to a cup of grapes or a whole banana. Uh, let's go back and look at that. As I know some of you might be upset you got that one wrong. So you can see here, grapes is 23, cherries is 18, a banana is 14. The best snack would be a cup of strawberries, only 7 grams of sugar. Even better than that would be raspberries or guava or cantaloupe if they want something sweet. If they're looking for something that's not so sweet, an avocado, half a gram of sugar, that does have some fats in it. But again, they wanted to know which fruit had the lowest amount of sugar. The correct answer is strawberries, 7 grams. And then for those of you who may have gotten our hypoglycemia question wrong, we see here the acronym TIRED, tachycardia, irritability, restlessness, excessive hunger, diaphoresis. And remember this image, they're sweating, hearts beating fast, they're hungry, restless, irritable because they're hungry, sweating because their heart's beating fast, and they're irritable and restless. So it's a continuous cycle. All right, let's do a quick review here. So we talked about, we checked off all of our objectives today. Identifying signs and symptoms of hypoglycemia and hyperglycemia, and what to do if we notice our patient's blood sugar is really high and they're in DKA, and what to do if the patient's blood sugar is really low. We talked about giving them 15 grams of carbohydrates, rechecking their blood sugar in 15 minutes, repeating the process if their blood sugar isn't above 70. And we also talked about hyperglycemia and a little bit less, because remember the plan for the insulin administration is very individualized for each patient. But we did talk about signs and symptoms of what to expect if a patient you suspect they may be in DKA. We also identified elements of a proper nutrition plan. We talked about the 9-inch plate to help us better provide the patient with balance and some dietary concerns. My patients always want to know what's a sweet snack they can have, and they want to know what's the best. So that's why I included a sweet fruit selection and show you the difference in sugar amounts as opposed to eating healthy and then eating healthy for a diabetic. There is a very big difference. Identify comorbidities which make diabetes more challenging, diabetes care more challenging. We talked about how hypertension and cardiovascular disease and chronic kidney disease, how they all play together unwelcomely and cause the effects of diabetes to be maximized and lead to microvascular changes that unfortunately put diabetic patients at an alarming risk for several types of diseases and strokes and just unwanted health complications, which hopefully stress the importance of why we need to improve our management of these patients by creating a good diabetes care plan. And we also talked about this, about the parts of the care plan. We talked about doing the assessment thoroughly to get the information we need. And lastly, creating expected outcomes and goals with the patient so we have a way to track our progress towards meeting them. Now, I want to thank you, everyone, for staying with me this past hour through this presentation. I hope you were able to take away some information that you feel strongly enough with to use in your everyday practice. Again, my name is Deontay J. Marquis. I'm a family nurse practitioner here in Southern California. And I just want to thank you again on behalf of my ALF training. And I hope you have a good day. Thank you.